Mark Kramer. Mark is from the University of Wisconsin. Those who watch our shows know him. He's a neurosurgical colleague, and he's much sought after. I'm very glad to see you here. I'm surprised almost, because every week there's another interview. It's nice, but all joking aside, he's a wonderful surgeon and scientist, and he is doing an exciting research project. Very cool to have you here. And we'll be joined by two other fellows. Two of our fellows are at an AO course. Bob, you'll be in approval in San Diego. We didn't plan that very well. And we'll start with something really simple, right?
That's right.
Here we go.
All too common. So we'll go through a few cases. This first one we have presented before, but it's worth presenting this to you guys today. So it's an 85-year-old gentleman. He's presenting after a fall. It was a mechanical fall. He was initially placed in a rigid collar. However, he continues to have some neck pain and some balance issues. He does have a fairly complicated medical history, as an 85-year-old gentleman here in the States would. Coronary artery disease, hypertension, hypothyroidism. He's also got a history of myasthenia gravis with some ocular manifestations. He's been on chronic steroids for that. He's also had some lumbar stenosis and previous surgeries in his low back. Nothing relevant in terms of cervical operations. So he presents with this fracture. You can see it's a minimally displaced type 2 odontoid fracture.
This is so common. It's not even a problem anymore. Ali, you still cover trauma call, right?
Sure do.
All right. Every night, right? Elderly patient, type 2 odontoid fracture, not very displaced, and your suggestion is?
Well, I mean, there's several options, right? So some people would argue to put them in a hard collar. Some people would argue to put them in a halo. Minimally displaced fracture you can treat with an odontoid screw. I mean, a lot of options. Some people would do a posterior fusion too.
Yeah. I'll put you on the spot. There are a lot of hypothetical options. What are you going to do? I'm the ER doctor. Dr. Musiwala, what are you going to do? Can I admit him to your service?
No. Typically, go to medicine service, we would consult, but all fun and jokes aside, yeah, I mean, you could try to treat this in a hard collar. My preference would be an odontoid screw.
All right. Wow. Age, dysphagia, no problem?
No, those are all real risks.
Okay. We'll not ask everybody's opinion, but I'll come to Bob in a second because he'll be very much needed.
Yeah, I mean, I think, it's a very common problem. So I think it's worth a conversation with the patient. I want to know what the uprights look like in case, to see if there's any displacement or not. But let's say it stays like this and it's non-displaced. I think that's where the grayest portion is. If it's displaced, then most of us would probably consider an intervention. In terms of just talking to the patient, you just need to talk to them about the risks of anesthesia and what. So operative intervention for me in my hands would be a posterior-based approach. I would avoid probably, maybe Jens, you knew this about me and you're pitting us against each other here. I think the odontoid screws relies on like great bony fixation, which I sort of, his bone stock looks better than what I would expect for an 80-year-old, but I'd still be a little concerned of resting everything on just one screw. It has a favorable morphology. But I would probably, if I was considering operative intervention, it would be a posterior C1-C2. But I actually would put it in the decision sort of on the patient and the family. I think this would likely do well with non-operative treatment with a hard collar for a couple of weeks.
Anybody volunteer? Dr. Turner, do you want to? Oh, his partner. You have a differing opinion from your partner.
Well, I just want to bring up a few things. So first of all, looking at the coronal over there, is he auto-fused down the lateral masses over there? Because that would also play into my consideration over there. On top of that, he's on steroids and isn't the peak of health. So if I were to do something operative, I don't think that thing's going to heal. And with him being fused below, I think that would be a lot of stress on an odontoid screw. So I would have a conversation with the patient about operative versus non-operative, but if I were to offer operative management, it would be a posterior-based approach. And with him already being fused, I would even consider going down an extra level or so for extra points of fixation.
Yeah, I don't have the sagittals through the facets, but a lot of arthropathy, no fusion.
Need some wise help here.
Well, I don't know if it's wise, but I mean, I think all those points are exactly what you want to look at. I mean, I would be really concerned about the stresses that you're going to put just from an odontoid screw standpoint. But the beauty of this is he's got a really sclerotic top part of that of the odontoid. So as you drill through, you're going to get one or two threads out of that and get great purchase with that. So I would, if I were going to do anything surgically, I would probably consider an odontoid screw in this situation.
Any fears about dysphagia, swallowing difficulties, elderly people, upper cervical exposure?
The beauty of that is that if you can see, he's already hyperextended, so you're not really going to have to dissect a whole lot. You can kind of start a little high and dissect down very, very carefully, elevate that up, and then with the instrumentation that we have right now, you're not really having to strip the soft tissues or anything. You can put your screw in fairly safely, and no, I'm not too worried as if you don't try to strip the whole esophagus all the way down.
Response by everybody in the room. I'm going to ask you some questions. Everybody. Who, if this is their grandpa, and he's neurocognitively with it, right? So he's oriented.
85 going on 60.
Yep. All right. Who would put him into a collar and send him home? Okay. Who would do an odontoid screw? Who would do a posterior primary fusion? The two uses after talking. A lot of talking. Okay. Colin, sorry, you have your mouth full. What would you do? Colin has just joined us. Colin Gold was very busy in the OR with me today. What do you think?
Collar and stand back and under two.
That's what I would do. Wyatt, you've been quiet. What do you think?
You haven't asked me anything yet.
Yeah.
That's why I've been
You
quiet.
were just out of my vision there. I got to reposition.
No, for this guy, I mean, he's 85. If he's a healthy, spry 85, for me personally, that's pretty good bone quality that he has in his cervical spine. I would put him in a collar. I would see him back in my clinic in 6 weeks. You haven't burned any bridges by doing that, you know. If he still has intractable neck pain at 6 weeks, or if that fracture fragment displaces at all, anterior, posterior, then it's kind of declared itself at that point. So for me, collar and follow up.
How many times have you given this recommendation today for this? I think several times, right? I mean, this is like several times a week that we have this. Take us forwards.
All right, so 3 months, he comes back. This is his imaging. We have a repeat CT, obviously no fusion. He says he's been wearing his collar, religiously. The flexion extension here shows a fair amount of subluxation. It's about 3 millimeters, 60 millimeters of translation, comparing flexion versus extension.
So here we are. The collar people failed. 2/3 of the room had voted for collars. David.
I just have a question. Is he in pain?
So he does report some neck pain now. He's still having neck pain, and he's also reporting some imbalance.
Okay. Because if he didn't have pain, I would just leave it. But with pain, that would make me lean more towards operative intervention.
And what operative intervention would that be?
C1-C2 fusion.
How?
Posterior.
How? Screws,
Oh, yeah,
wires,
screws.
cables?
Yeah.
Screws.
No, screws.
Transarticular?
No, I would just put lateral masses at C1 and then pars screws at C2.
So response from everybody in the room at this point in time. So most of the people, myself included, had voted for a collar. Now this is not so good anymore. He has pain. He's an active person. There's a whole family sitting around with their arms crossed going like, what are you going to do now, doctor? What are we going to do in Kentucky?
Yeah, I mean, I think at this point, if he is still having appreciable pain and maybe some balance issues, I think if I was going to do something, I'd agree with doing a C1-2 posterior arthrodesis.
Screws.
Screws.
Bone graft. Ryan, want to weigh in? Then we'll.
Yeah, I think he would get the same thing at our place. Posterior C1-C2 screws.
Okay. All right. You two?
I would have already operated on him. You burned the bridge here.
All right.
So now I can't put a screw up there because if you look at the odontoid, it's kind of mucked up. So I think you now have to go. Posterior.
All right. Next.
Sounds good. So this is what was done.
Dr. McGuire. Tell us
Old
what
school,
it is.
brother. Old school.
Don't look at me. Don't look at me. What is
That really works. This is a great way of fixing things if you know how to put a wire in. And the real mistake that people have with a Gallie type fusion is the fact that they don't get their grafts tight. They don't really put the contour of the graft appropriately. And the next thing that happens is you start getting wobbling. And then because the fusion's not taken, and then the wire breaks. So that was one of the things that we learned. So basically, instead of just a standard Gallie, you augment it with maybe sublaminars on both sides, or this would be an ideal situation for a transarticular screw.
But here's a cable. Now, who's going to vote for this is going to work? This was done 5 years ago. Raise your hands if you think this is going to work. Anybody? Dr. McGuire says it's going to work?
I worry a little bit about the inferior aspect of that graft sitting in the transverse process. So the wiring looks pretty good. This is one that time will tell.
So before we go on, we have to say, again, this is a technique I was never taught in training. But if you are going to do this, this is an allograft. Is that how people are taught to do this? For those of you that are familiar with it, tell us more.
Yeah, this is you really need to use an autograft here, and you take an H graft from your iliac crest, so you contour that around. You also decorticate the posterior aspect of the arch of one, so that you've got some good bleeding bone there. Because if you put this on that sclerotic area, it really is a problem. That's where these things usually fail. But the H graft then fits in between the spinous process and then the two legs of it after you burred down part of the lamina of C2 so that you have good, bony contact. Then the wiring, you have to absolutely make sure that you tighten that wire down. And then we went from wires. The problem is you put your wire in and it loosens really quick. So the cables, when the cables came out, then that made things a little bit easier because you could really ratchet things down a little bit. But the autograft is where you really get your the allograft situations. I went to allografts years ago because that was so much easier than making a big hole in the pelvis. And but they didn't quite fuse as well as the autografts did.
So wise words. I was taught. I'm old enough. I was taught in doing this, and this is a Brooks cable actually that was done. So sublamina, not a Gallie. And we used tricortical iliac crest graft. Dr. Anderson taught us very well.
And the Brooks works really, really nicely because you've got two cables in with the on each side, and then you can also augment with the Gallie to hold your graft in. But the Brooks is where you're really getting your stability.
But we were also taught we need a halo with this because this actually doesn't do so well. So the tension is mounting, Mark. Take us forwards.
Fair enough. So again, this is about 5 years ago. Actually does very well after this. He gets back to his normal life. Again, 85-year-old guy, he was going on 60. He was actually doing very well. Now, he presents 5 years later. He's about 9 years old. Over the last year or so, he's had a kind of gradual decline in his function. He lives with his spouse. He's still, living at home on his own. his spouse over the last 6 months is requiring more and more assistance for daily activities. And then really it's over the last month or so that he's become quite weak actually now. Now he can't really even stand on his own. He can't really, he can't walk. He's requiring a lot of assistance from his spouse. Again, she's an incredible human being. She's able to care for him this entire time, but now presents to us, comes to our ER, and you can see based on the exam here, pretty profoundly weak. Upper limbs, more so on the right side than the left in the upper extremities, but also very weak in the lower extremities. He's unable to feed himself anymore because his grip is so poor. Despite this, he's actually not in any pain. And you can see he's got brisk pathologic reflexes. So this is his MRI. Again, because of the wiring construct, very difficult to see. But you can see that there's suggestion of severe stenosis at the area that the fusion was performed at C1-C2.
You got an X-ray, by the way? There we go.
So we got initially a CT, and this is what the CT shows.
Only reason I wanted to say about the radiograph is because if you look at the MR, if you're looking at that picture, you got all your scatter from your stainless steel. So that's going to be an issue. So you really can't go, on the MRs at that point. So you really need to have, something else with that. So that's my only comment.
And if you look close, one of these wires is actually broken. It's a little difficult to tell based on the sagittals here, but so we actually, we were pretty convinced that this was, severe stenosis causing his symptoms. We did get a myelogram as well. This is the myelogram.
So why did that happen? You talked about it. You're the only one next to me who's done this technique before.
So now what you've got is a little bit more of an issue. So, so now you're going to have to take all that off, and then you're going to have to open up the foramen magnum just a little bit to be able to get your fixation to your occiput into that area. But I would go from occiput down to probably 3 or 4. No, I wouldn't stop because I've got a subluxation at 4 on 5. So if you stop there, then you're going to worsen that area. So I would probably I'd probably go down to around 5.
I was fascinated by this case because, again, I'm old enough that I was trained in doing this and I've done these. Again, sorry, this is not my case, but I was not happy when this was done at the time. But the real problem is we're trying to predict survival of our patients. And
you can't do it. I mean, it's as much data as you think you have. You just absolutely can't predict that. I mean, it's funny over 40 years that, I've looked and you think, okay, that guy's on death's door. Next thing you know, he's still alive 5 years from now, and you've got a fracture that you maybe didn't quite fix.
I'm pretty sure we're co-authors on one of those papers where in the 80-plus-year-old rate, 1/3 of patients dies within 1 year, regardless of treatment.
I mean, it's unbelievable. So,
now he's 90.
As I got older and older, I became more aggressive in my treatment.
So now he's 90. Still do it? Let's ask an ethics question. Who wants to do something surgically? Raise your hands. Dr. Ramey is right up there.
Yeah, I mean, this poor guy's suffering. He's 90, but if he's as good of a 90 as you say he is, then I think there's enough justification for treating him surgically. How I would do this exactly, I would not respectfully go to the occiput on this guy. I would take a little bit and do a little bit of a suboccipital craniectomy on him. I would obviously do a C1-C2 laminectomy and remove that. Move the wires or cables that were put there and do a C1-C2 fusion. Maybe go down to C3, but I think you can get away without going to the occiput here. But I think you're more than enough justified treating this guy, despite his age.
Amir, do you want to Tell us about it. Samir pulled the lottery card. He was attending.
Yeah, so I was the one who had the joy of getting this on call. So you can just take us forward and see what we did. So yeah, I did not feel comfortable just going to C1-C2. We were able, fortunately, to get all of that hardware out without any, durotomy, which with the broken wire was a big concern. That's a tricortical graft we put in there with some cables. We're able to get a nice decompression at C1-C2. Unfortunately, I have not been able to see this gentleman. This was fairly recent. But he, even early postoperatively, had a significant improvement in his hand function, both sensation in terms of feeling a little bit stronger as well. So I agree with you guys. I think it was, I didn't feel that just leaving this person to, progressively worsen would be, ethically appropriate. And this is what we did.
Is that a swallowing study?
Oh yeah, this is a swallow study. Yeah.
I love those.
Yeah, I just thought it's kind of fun to see. You can see it nicely moving
Now
as a
you would
unit.
not get that with an odontoid screw. I can tell you that much. Even a well-placed one. I can watch those for hours. So, but there's a lot of lessons there. Older patients, they still have a life to live. We can't predict them. And there's some administrators who always tell us we're spending too much money on our care, but one definitive rigid fixation would have probably obviated that. Wyatt raises a good point. In older people, especially, we don't want to go to the occiput because when they try to walk, they lean forwards and then they fall over more or they kyphos. Any thoughts about that? Should we flex older patients when we do have to go to the occiput? I agree with Amir. I did not see much of a C1 lateral mass there.
Yeah, I had to look at the lateral mass a little bit more closely. But older folks, occiput fusions are very, very morbid. And the more you flex them, the more potential you have for dysphagia in those patients too. So it's not just the odontoid screw that you're worried about dysphagia, it's these occipital fusions in older patients as well. So, I'm giving a talk on that tomorrow, so I'm a little biased, but try to avoid it when you can.
Should have listened to Ali, odontoid screw. Seriously, do you do this in older patients?
I do sometimes. Yeah, you trained me how to do the old bony fusions. We didn't have lateral mass screws and posterior cervical screws like this when I started my training. So, I think all options are on the table. I would agree that you always worry about dysphagia the higher up you go, but in the original imaging, I think you could have done a C4-5 exposure and then got up, and it would have been pretty straightforward. So, like many people, I've been in practice for a while, and so I've seen my own failures. And so in a lot of these older patients who are really active, I haven't seen a solid fusion occur at that C2 level. And for that reason, if their anatomy allows it and they're willing to do it, I think you can place, 2 screws in a lot of these patients. They do pretty well, and you haven't burned any bridges. So a lot of people haven't done odontoid screws too. So I think there's some learning curve too.
All right, one more case. Let's run through this one quickly. But Dr. Kramer's our geriatric spine surgeon specialist here.
Okay, so also octogenarian. So a very common problem we see. 80-year-old gentleman, he presented with low back pain and right leg pain after he had this L2 compression fracture. You can see it from the X-ray. He had and it was kind of lost. And as I look back through the charts, exactly how this occurred, I presume it was just a minor fall, but it actually was kind of lost throughout his history of all of the notes that I reviewed. His primary complaint, like as I said, was kind of low back pain. He also had some paresthesias and pain kind of radiating down to his buttock region. He does have a history of some common comorbidities, atrial fibrillation, hypertension, prostate cancer. He had previous prostatectomy, no previous spine surgery. And he's a businessman over on the east side of Washington, non-smoker, very physically active. So the story kind of begins here, and this is kind of a narrative kind of review of his history. So Again, minor trauma. He has a lot of back pain, goes through a lot of workup. Initially gets this MRI. And he initially, due to the back pain that he was having, ended up undergoing a kyphoplasty at L2. And then continues to have back pain, gets another MRI. They see a little compression fracture at L1 as well, so he gets a kyphoplasty at L1 as well. Does okay for some period of time. If you look at the history here, we're going on about a year now. Now he's having recurrent back pain again, and now he's having some of the symptoms I had already mentioned, some of that pain running down his legs. So he starts getting a bunch of injections. You can see he's got 3 injections over the course of 3 months here. And then at this point, finally gets an MRI. Again, this is going on a year after his initial kyphoplasties. And you can see at the level where the 2 kyphoplasties were, L1 and L2, there's pretty severe stenosis at both those levels. And here's the exam that he presents to us with. So some mild left-sided weakness. You can see he's a pretty average sized gentleman, BMI 25, very mildly kyphotic posture, but actually fairly active, fairly robust 80-year-old. He's ambulating with a cane at this point due to the low back pain and the leg pain. And we initially get this CT. And this CT shows, I'll kind of scroll through this as well. You can see pretty severe retropulsion now of that L2 compression fractures kind of breaking apart. You can see all that concrete material in there as well.
That's a really nice presentation. Yeah, so here we are. Super active guy, 82?
82 at this point.
82, very successful business person, still involved in everything, extremely unhappy, can't walk anymore, and has back pain. What do we do? Looking for help here. Who wants to join in? Ashraf, do you want to be my initial partner?
Yeah, so he has a fair amount of stenosis in the setting of a progressive fracture that now has cement in it and probably is never going to heal. Yeah, I think he has stenosis. It'd be reasonable to do a decompression infusion, keep the laminectomy pretty narrow. I would probably do an ultrasound at the time to see if the nerve roots or the conus is still draped over the anterior, the posterior wall of the vertebral body that's sort of retropulsed. I would assume that it would, you'd probably be able to free most of it, but if it's still an issue and you can't reach it, then the options at that point would be just to take down one pedicle and push it away. But you could probably limit this to T12 to L3 there.
And junctional levels, what do you do there? HU, it still looks so bad, but I'm not sure what we measured there because it looks pretty bad on the CT. So, Amir.
I was just wondering, is there any concern that this might not just be a basic fracture, that there may have been a tumor there in the first place?
Could be. This was done in an outside facility.
Good question. I don't know if any contrasted MRIs were done. I'd have to go back and look.
The historical context will disprove that, but any role for a decompression only? Ali, outpatient surgery center? Nope. Go big or go home? Are we going big, Bob, or are we? This man at this point in time, this is a functional guy, has been successfully turned into an opiate addict. I mean, crazy doses of all sorts of really bad stuff.
Well, that does change things a little bit. I mean, I was thinking just decompress it, if like you put your finger on your eyeball and you push on that, that's a nerve, and all of a sudden your eye starts hurting and you take your finger off, your eye feels better. So, you got the same thing here. You got pressure on your nerves. So if you just decompress it, you may get by with that. I didn't see anything on flexion extension that made me think that this was grossly unstable. So I think you could, this might be a situation where I would do the easy operation, see what kind of response you go. But I'd be very, upfront with him. Hey, look, this is what we're going to try to do, and if this doesn't work, then we're going to do the big operation. So I might at this.
Full laminectomy?
Yeah, yeah. Leaving facets intact, though.
So I guess the more full stories we presented to us, this is during the COVID pandemic, and then was seeking multiple surgical opinions. So we all leave our surgical options discussed from us to the end. But this is ultimately what was done. So he had just had a decompression, both at 1-2 and 2-3. You can see it's nice, widely open. They took down all the posterior elements as well during those decompressions. So now he returns 9 months later, and he's having continued pain, low back pain, and claudication-like symptoms, pain radiating down the legs, can't stand long. And here's his new MRI.
Now you got a real easy operation here. You do a far lateral, go retroperitoneal, take the vertebral body out, put an implant in, and then percutaneous from the back. One level up, one level down.
On the last slide, was his pedicle fractured, or did I just...
I'm sorry?
He has a pedicle fracture there as well?
Yes.
Yeah.
So here, my major concern with that last operation, the laminectomy, is you've got an image done 2 years prior with the Kyphoplasty, right? And then you've got another image 2 years after that with severe stenosis and a new retropulsed fracture. So to me, those anterior two columns of the spine have already proven that they have failed, right? And so if you remove the posterior column at that point, full laminectomy, you're setting up this guy for failure in my opinion. So for me, it's a T12 to L3. If you're going to do a laminectomy, you've got to insure this guy.
I had suggested a decompression only and to put a Coflex spacer in to hold it at the upper end and not sacrifice the midline.
And you know that certainly is an option. Going in on one side, then kind of coming underneath and being able to decompress that. You leave your ligaments and everything intact. So that certainly is an option to do that. But I've not had a whole lot of success with. I've taken a bunch of Coflex out. I've not put a lot in. So I saw all the bad things that were happening. So I wouldn't have. I probably wouldn't have done that, but I might have done just a decompression, going in on one side, trying to save all my save all the soft tissues there.
All right. So now let's carry this forward. So now we have an escalating problem. Opiate addicted man. I think what Ashraf says is so insightful. And David, you had a thought also. I think he had AVN. I think he had Camel's disease and just destroyed that vertebra.
Well, that was part of my thought, and one of the reasons I was kind of quiet when everyone was discussing, which is very atypical of me if you ask Ashraf, is because I was going back and forth what to do. I mean, it's clear to me that this is probably some kind of heat necrosis, AVN type scenario that caused it. It's an incompetent level. And in my mind, I was actually going between a laminectomy versus lateral corpectomy. Also, I don't think that piece would have been that mobile. And so my dilemma was, even if you do the full laminectomy, you still have that anteriorly, and I'm not sure how much you'd be able to move it without a corpectomy. And so I wasn't quite sure. That's why I stayed quiet.
That's why it's an easy operation now. He's already proved it.
Yeah, I mean, he's proved it, but then it's the philosophical question, do you do 2 surgeries or do you just do one and done, And I don't know the answer to that, but that's also why I was kind of a bit quiet on it.
So it's
All right. Surgery.
So it seems like the consensus is rebuild the anterior column and then fuse posteriorly, which is ultimately what we did. So it was a revision laminectomy, 12 to L3. Due to all the scar, it was quite a laborious case, it sounds like. I wasn't there myself. But in this case, we did a full corpectomy posteriorly. And you can see, I believe these are 2 cervical titanium expandable cages that we were able to place by sparing the L3 nerve root. So, and then we fused all the way down to L3, 12 to L3.
Cement,
and then
so UIV plus LIV
I should also
minus,
mention, let me
cement
scroll
in
through.
there.
Yep, cement augmentation for those different levels.
So you also put the cement level below.
Exactly.
Yeah, LIV -1, UIV +1. And we use dual cages to save the nerve roots. I think Dr. Oskuyan, who's a master of XLIF, was not around. Are you able to get these cement blobs up? Would you have been comfortable to do that, Rod?
Yeah, I mean, we've done cases like this before. It's actually much easier than it looks because you just go in there, do discectomy, and the cement comes right out because it's actually easier than taking out fractured bone.
That'd be not
So,
united.
yeah.
And for the record, I hate cement. But the patient did how?
Patient did great. Yeah.
Great. Yeah, he wrote us a very nice 1-year anniversary note. Very nice, indeed. So, I know. And Wyatt, we've talked about these dual cages. Have you done those before from the back when we want to preserve nerve roots when Rod is not around to do an XLIF?
No, I haven't used the cervical cages like this before.
Yeah, it's actually very gratifying.
I'll do a singular.
Yeah, I thought they're too small a footprint, but we put them on the apophyseal ring and held up quite nicely so far. All right. Colin, do you want to? Thank you, Mark. We have about 20 minutes. Colin, do you want to? Which case do you have?
I have 3 different ones.
Okay, we'll rapid fire through those because then we have Cliff. I saw Cliff coming in. We want to have a grand finale of 9/11 driver. So these are 2 cases have not been done yet, right, Rod?
No, yeah.
I'll give you the microphone.
One is halfway done, and then the other one I think we did recently. So.
All right. First case. This is a mid-30s-year-old man with a history of cervical spine surgery that was done in Mexico after he had a diving accident where he dove into the ocean onto his head, and cervical intervention there. And then he presents to us with progressive neck pain and prominent hardware in posterior neck. This is his motor exam. You can see weakness in both uppers and lowers. This is his baseline. He's wheelchair bound since the accident. Really no changes from baseline. Here are some flexion extension x-rays when he presents to our office. So you can see they fused to occiput in a relatively kyphotic position, and then the inferior screws are pulling out. So here's some CT scans, or static pictures of the CT. Midline, you can see the kyphotic deformity, screw pull out bilaterally at the inferior portion of the construct, and a rod breakage on the right side, just above the lower screws on the right. And this is just a static picture of his MRI. You can see the intrinsic cord signal change. That's from the chronic injury. Should pause here for discussion.
So I want to move through these rapidly. So the presenting complaint now is what?
Neck pain, prominent hardware, and pulled out screws.
So we'll go straight to Dr. Ramey. My favorite thing, and yours too, without anticipating a lecture too much tomorrow, I think we think alike there. What's your critique on this thing, and why was this done?
So I look at that MRI, if you can pull that back up. It looked like the injury was at C3, C4.
I believe so, yeah. We didn't have any images of Mexico.
So why in the world did they do the surgery that they did? You know, that's what I look at. But neither here nor there. We're in the position that we're in now. So I'm looking at this and I'm thinking you probably have to go back front back. If the goal is to restore lordosis, then you got to go back front back. If the goal is not to restore lordosis and just get more adequate fixation, then you probably just need to extend it down a little further. Does he have complaints of kyphotic
He's
of
mainly
kyphosis,
wheelchair.
or-
He's wheelchair bound, so,
So
the
definitely not
kyphotic
then.
deformity is not really a big issue. It's more the hardware prominence
see.
and the neck pain.
I'd probably just extend them down and revise the hardware then.
I think, I mean, if you go back to the post-operative one with the hardware, the X-ray there, I mean, he's pretty extended at the occipital cervical junction, you know, which is then going to have you flex a lot more and put a lot more strain distally. So I think if you look at the back of the mandible compared to C2, like especially on that flexion one, it's quite extended. So now we've, you know, he's trying to self-correct one deformity with another, right? And so, and that's probably what predisposed. I completely agree with you, Wyatt, in terms of the number of levels is probably more than what we would guess he may have needed based on the MRI. But if you're going to go up to the occiput, just be wary of the position that you put folks in, because there's significant consequence to that.
I find this pretty sad because I see a lot of surgeons putting in hardware into the occiput that's life-changing, and it was really not necessary. So what do we do, Colin?
So the plan was to do some hardware removal and exploration, and what ended up happening was removal of the occipital plate, C2 to C6, revision of the screws with all the old screws removed, new longer screws put in, and actually did not put any occipital hardware back there with just good long C2 screws and longer lateral mass screws. There was good fixation.
So he'd never actually been orthodesed to the occiput, so we just let him go. And even C1, C2, we just let him go. He regained his motion. Final upright. I should have probably gone to C7 now looking at this.
So you feel like this patient did noticeably have improved motion?
Yeah.
That's very,
We've had a
very
couple of those
fortunate.
patients where we just get CT scans. If they're not formally fused, we just take the hardware out from the top.
I think what you did was very, very benign. Very much agree with you.
Yeah, I mean, you can see the mandible now is, you know, sort of parallel to C2, whereas before it was extended. So it's definitely flexing more.
Just out of curiosity, did you think about going from the front? Just taking
Yeah.
all the hardware out and then going from the front?
Yes. So I'm a little bit worried about
Yeah.
swallowing difficulties. He's an incomplete quad. He's a
Sure.
C6 Asia C. So he can actually transfer, but not much. But I did not want to overthink this and overdo this.
Yeah.
And he's pretty skinny also. I did not want to dwell with feeding tubes and stuff like that.
And then how about in the OR? What did you do for positioning and?
I used the Rod Oscuian life-changing thing. Gardner Wells tongs. Thank you, Rod.
Yeah.
No more Mayfields.
Yeah.
Thank you eternally. All right, let's look at another one.
All right, so next one is a mid-30s-year-old man who presents to the ER after a tree fell on the tent where he lives during a cyclone. Of note, the patient's mother was in the tent with him and was killed in this accident. The patient had the tree land on him himself. He presented non-ambulatory due to pain in his low back. This is his neurologic exam. He's intact on exam in the emergency department. And this is a CT scan demonstrating an L1 burst fracture.
Rapid fire, Dr. Gendelberg.
And notice a compression fracture at the level above, T12.
So T12 A1 injury, L1, I think it's an A4,
A4,
almost
yeah.
inferior end plates blown. See, we do our AO classifications, Bob. We apply them. Bob, Mr. AO himself. Fix, no fix? Yeah, microphone.
Well, I have to agree with my own literature, don't I? So at this point, I'd put him in a brace.
Homeless guy. The tent's gone.
Well, you know, we looked at this thing. It's interesting when you look at A3s and A4s. There is a regional, classification and the way that they get fixed or that they get treated conservatively. If you're in Germany, this would be fixed automatically.
Absolutely.
And but if you look at the long-term effect of treatment conservatively versus surgically, they're basically the same.
Is there a role for upright X-rays, or would you get upright radiographs before it's just saying you're going to definitively treat it? Okay.
I mean, if you're unstable, if you're really moving around, then that changes the whole problem.
We're going to Kentucky. Fix, no fix, brace.
No, I think upright X-rays, and I think bracing initially is a very reasonable option.
Now, Bob, two-level contiguous fractures. Does that change your thoughts, Dr. McGuire? Two-level contiguous fractures. No, but just the kinetic energy.
That's, I think if that one, the level up above is as bad as below, that would change for me.
I need some help. I need somebody to back up what I was gonna
Okay,
do. I'm
how
gonna
about
walk
I
over to
back
Dr.
you up?
Laney.
Okay. Oh, do you want some backup?
Oh, you go.
I think that looks pretty kyphotic. I'm all for getting uprights to see what happens, but I'm willing to bet that that'll kyph over and will probably end up being operative. And yeah.
Front or back?
I would do a lateral corpectomy, go 2 above, 1 below.
Yeah, I can pretty confidently say 80 to 90% chance there's kyphosis in an upright X-ray, probably more than 10 degrees. And if that's the case, then I'm gonna operate on this also through a lateral corpectomy. What level is that? 5, 4, 3, 2, 1.
1.
With that fracture that's there, 2 up, 2 down.
2 up, 2 down.
2 up, 2 down. Yeah.
Dr. Gold, you're from the University of Iowa, neurosurgical colleague. What would you have done in Iowa?
I think the fact that he's homeless, I'd say is kind of high risk for him not
Living
showing up
impaired,
again
right?
and
What should we say now? Living impaired?
living
Homestead
impaired, temporarily unhoused.
Yeah, unhoused.
But anyway, I think there's a big risk that he's not going to show up again to a scheduled appointment, so we won't know that there's kyphosis, and then he'll come back to the ED with a really, too far gone situation to have to do a bigger surgery. So my inclination would be fix this while he's in the hospital.
All right, so let's see what we did.
All right, so we did only part of the surgery so far. A T11 to L2 posterior fusion, and then we did a open reduction internal fixation with the ventral compaction of the fracture fragment. And this is his post-op CT scan from the first stage.
And second stage is Dr. Oskuian, the XLIF king. Right, Rod? We talked about this. Why should we fix them? What's your thought?
I think you could try to brace them. I think the social and the kyphotic deformity, I think probably are gonna not help him, and I think L1, and he fractured T12 as well. So I think it's reasonable. I spent a year in New Zealand where the surgeons there, like Bob said, it's very regional, and they were super aggressive with fractures, but they almost never went anterior. They would go 2 above, 2 below on everyone, and they never did corpectomies. And in their experience, and I've seen this too, is, in a young person, that bone will remodel. They will have some kyphosis there. That's the only downside, but it's like, they don't really care about that. And I don't know Jens and Bob's experience, but I think the argument for me is, I think you probably, like for someone like this, there's no question they're going to kyph a little bit if you just go posterior only. I don't know what you think, Bob.
The other thing, from the kyphosis, it's usually not the thoracolumbar kyphosis that's bothersome. As they get further and further down the road, it's the low back pain.
Yeah.
Because they're hyperextending at the 5-1 junction. And that particular issue becomes real problems, 5, 10, 15 years down the road after you see these.
Jens, I think I know the answer to this question, but why did you decide to stage it?
The master of XLIF wasn't available. I was doing plenty of cases that day, and we can talk about that tomorrow also. Staging thoracolumbar trauma. Short segment fixation posterior works perfectly. You need to have about 2 weeks time frame until you have the anterior column repaired. And in my experience, especially vulnerable patients, they just need to have a bulletproof construct and decide, how much blood do we lose, Colin? How much blood?
Maybe 150, 200, something like that.
Yeah, very atraumatic in 3 hours.
Yeah.
2 hours.
And the patient's pain is actually nearly gone, just from no surgery to surgery.
will save. If this was an older patient, I probably would have gone 2 up, 2 down, and cement augmented my UIV and LIV and called it a day.
Yeah.
How about intra-op, Jens? What did you guys do to get it? Because it looks like you did a really good.
We used our impactors, our TAMPs, our bone TAMPs. We did limited decompression and got around the dural sac, and then under fluoroscopy did metal myelogram and ventral impaction, left and right.
Did you try distracting too?
No.
No.
Ligament metaxis is it's insanely crazy because the PLL is torn, as it was here, and so it makes no sense to rely on the PLL. Any burst factor over 50%, this is 70%, the PLL is gone.
And then Jens, what's your sort of threshold for taking down the pedicle to do a decompression?
Low, very low. This one actually on the left side was busted. I could have done this probably from the back also, but we wanted to just get him stabilized, get him moving, and wait until the XLIF King is ready. All right, and one last case from you, and then we have the grand finale, the 911 racer.
So this is a mid-70s-year-old man who was testing the self-driving mode in his car when the brakes suddenly engaged, and he came to a stop but hit the car in front of him. He was going about 50 miles per hour when the braking mechanism started. And the airbags did deploy. So the patient had neck pain but was ambulatory and was able to self-extricate from the car. He was neurologically intact in the ED, but he had things to do, so he left the ED AMA the first day and then represented to a different emergency department the next day with worsened neck pain. Here's a CT scan.
So Asia E, motor score 100, and there's a kicker to it.
Yeah, so we can see the C1 anterior and posterior arch fracture. And then you can kind of slightly see on the left side some displacement of the C1 facet on C2. And then I think on this coronal right here, you can just see bone in the C3, C4 vertebral foramen. Yeah, I should have paused it right there on the axial. So his vert is out on the left side at C3, C4. There's a CTA that was done, but
it reconstitutes on the top.
Yeah, it does reconstitute, but
Yes.
no imaging available for that.
So no antegrade flow at C3, 4 upwards. So now this is and there's no MRI yet, right? This is a case that's not been done yet, so we would appreciate all your help. Dr. Askuyan is the attending, so I can gladly we have an MRI.
There is an MRI.
So left side of vertebral artery is out. Self-driving experiment failed. He's shopping around now for trial attorneys. And he has a lateral mass atlas avulsion fracture. Did we look for the TAL? I mean, it must be torn, right? TL is gone.
Yeah.
So what do we do?
Yeah, ADI is pretty high in this case. For me, I think this is I need to look at the lateral masses again, but there's clearly no occipital atlantal dislocation or instability, anything like that. I think this is a pretty clear-cut C1-C2 fusion for me.
Lateral mass avulsion. Ashraf, what do you think? UCSF.
Yeah, I would see. I mean, it doesn't seem like it's terribly displaced. If go up to the axials again, I'd probably get uprights. Oh no, it's actually displaced a fair amount. It looks like the overhang there is probably over, our cutoff usually of 7. So if he's active, I mean, I think, and you have an intact lateral mass. I mean, and the lateral mass isn't eroded. Like a C1 ORIF would be sort of be how I would approach this. It's a motion preserving surgery.
C1 ORF.
Yeah.
Now this left vertebral artery is out.
Okay, so
what are you going to do about the right vertebral artery?
Not hit it. Yeah. Yeah. So
the Brits call that a bum pinching procedure. I'm not going to translate that into Americanese.
Yeah. I mean, I think it's anytime we do a C1 or C2 fixation, the vert is sort of at risk. So this doesn't really change that. It's hard to know whether that was,
So C1 ORF. Amir.
Yeah, Ashraf, we were talking about this earlier. I find that it's challenging with a polyaxial screw to get control of that lateral mass.
Absolutely.
Tell us how you do that.
Yeah. And so we've gone to different companies to see if they would make us a solid screw, and none have, because they'd make tens of dollars. So what we do is we put them in, we spin the O-arm, and then that gives us a good sense of what's happening in the front. It's the same, because we can't, you're sort of, we can't control the front. And then at that point, if it's still diastasis in the front, then we'll in situ bend the rod after the screws have been locked to try to close down the front. Right. So, and sometimes it does require more than once. It might be an iterative process. But that's the way that we approach closing down the front. And as long as the overhang isn't, if you've corrected the overhang, then that's, but sometimes, because if you use the compressor, sometimes it distracts the front. So it's just lock it down and then just use the rod.
Yeah, we actually have a nice case. We actually have a nice case where we kind of tried to bend the rod beforehand and close it down. The reduction was okay. And then actually Ashraf just got annoyed and he inside to bend the rod and we got another spin and it was perfect.
Bob, what should we do? Fix C1-C2 fusion? Not an occiput to C2. I'll just take it out again.
I'd do a C1-C2. I think that's a reasonable route to go. I was going to ask a question. Anybody had any experience doing a C1-C2 fusion anteriorly?
I know the Germans and the Montreal group presented on that, and for some reason, one of the Montreal people was a little bit of a mole. They stopped doing that because every patient had dysphagia.
It's terrible. It's really, the fusions work great, but the post-ops are awful. But and I tried in my career, I did 2 of them that way, and I decided this is not what you want to do. But the bone fuses beautifully with that.
And then we have our German friend Frank Canziora from Frankfurt, who has an anterior C1-C2 plate that he puts in transorally, because in Germany, evidently, they have different oral pharyngeal microbiomes, so they don't get infected there. So
I'm, very simple-minded. And so with the C1 ORIF, you're just putting C1 screws, and with the C1-2, you're adding screws down the C2. So what do adding those two additional screws at C2 offer for this injury is sort of my question.
The main thought is C1-C2 stability for an avulsed.
I'm not sure the TAL is intact.
Yeah. So TAL avulsion. He probably has a TAL avulsion. So that's the only thing, and he's an older patient. But I'm with you actually. I would do a C1 fixation. And Dr. Scu and I have religious warfares all the time. He's a root burner. He's a neurosurgeon. He tears the root apart and just does very low risk C1 lateral mass screws. Whereas I do palm screws that Dr. Ramey and I published on, and we preserve the C2 root, but higher risk part to the vertebral artery. Rod, what are you going to do?
When I saw him, he was already in a collar. And he was also on Eliquis. He has a history of DVTs, and he's an interesting guy. He definitely did not want to have surgery, and so
Halo.
Yeah, that's.
I would give him a halo.
Yeah,
we've actually.
They tried to put him in a halo, and he ran off.
I have a paper with 3 patients. It's just 3 patients.
Yeah.
I think I got it published in Spine. We had 3 patients with this lateral mass avulsion injury, and we put them into halos. They all 3 failed. It's scientifically meaningless, but the revision surgeries were actually quite complicated. We had to do like a coronal osteotomy, but an allograft occipital condyle to C2. So the repair was not without trepidations. They looked beautiful in the end, but they had occiput to C3 fusions. So I'm for a C1 fixation.
The trouble with him is, it's not going to heal. It's going to splay more. And then, when you do the surgery, it'll be hard to reduce it. And I do think, I'll probably have to do a C1-C2 fusion at that point.
Yeah. No, but if that fails, they need an occiput to C3 fusion. You can actually, I can send you an article. Yeah. We have some very descriptive pictures of, they get this post-traumatic cock robin.
Oh, yeah.
And that's no fun to take that apart.
And then the lateral mass starts falling off the side.
And the vertebral artery gets kinked even more. Yeah. All right, we are at 7:30. Cliff, would you be okay? So how long is your lecture?
I can make it as long or as short as you need it.
So let's go for Cliff, and then you're on for 25 minutes. Is that okay? Cliff,
No
we gotta speed. This is not a self-driving car. This is a good old German Zuffenhausen product. And this is Cliff Pierre. He was a great research fellow with us, and he's now going for additional training. And thanks for making a comeback. He's one of our research fellows also.
Excellent. Hello, everyone. I'm presenting a case of a 72-year-old gentleman. This is going to be a staged presentation because he did present at another outside institution with his initial injury. He had presented after a rollover MVC. He's very active. He works a lot with vintage cars, and so this is what he got into trouble with his accident. Presenting with neck pain, mid-back pain. They initially treated him conservatively after getting imaging. And so here we see jump facets at C6, C7, some cervical spinal stenosis as well. One thing not noted, because we weren't able to get it from the outside institution, was his lower fractures at T5. He had a burst fracture there as well. This was the staged image. They treated him conservatively. He saw multiple spine surgeons prior to getting any further management. After about 2 months, when he had developed some pneumonia and some further complications, then he underwent surgery at the outside institution, underwent a C2 to T7 posterior instrument infusion with closed reduction of that cervical fracture at C6-7, as well as fixation around that T5 burst fracture. And so this was the imaging, post-operative imaging x-rays after he had that procedure done. He comes to us now a year after this incident and procedure with further neck pain, stiffness, and now has bilateral hand tremors. And this is his imaging, sagittal and axial views. This is the lower instrumentation views as well. So, again, some lucency noted at some of his lower instrumentation, his hardware, and starts to pull out as well. So.
And the cervical spine is not reduced, and the cervical spine is actually dislocated.
Yep.
So the yep.
And so now what?
So what went sour in that first case? So you had a cervical 2-level fracture, kind of a subluxation dislocation, and then he had a thoracic fracture. So what went sour with that initial fixation? I'll just go straight to Bob. They didn't have neo-spine equipment, I know that.
You know, the real issue here at this point is how do you get there? Mm-hmm. You know, you're going to have to put some sort of anterior column support on this thing to be able to get any sort of reduction.
Okay.
And if you look at the manubrium is right there. So what you're going to have to do is basically do an osteotomy through the clavicle, and then through your sternum, and roll that piece out to be able to get to that, and then work between the bifurcation of your vessels as they come off. So that you've got to have some type of anterior, anterior support.
Yep.
And then, of course, the posterior is pretty easy once you get it decompressed in the anteriorly. Then you're going to get some of that correction, and then you just use your posterior fixation to stabilize that. But that's a hard area to get to. But I think if you don't try to go anteriorly to get some support, then whatever you do in the back is going to fail.
Gotcha.
Yeah, but what went sour in the first place? Wyatt, any thoughts? So are you familiar with this case?
The anterior column.
No.
The anterior columns.
Yeah, but he had the T7 or a T5 burst fracture, and then a C6-7 fracture dislocation, right?
As well.
Yeah. I mean, I'm sitting here wondering what they did with that cervicothoracic junction, because it didn't seem like on the initial imaging that he had any type of hyperkyphosis there. So I'm not sure what happened, but what I can tell you is that T5 fracture fragment does need to come out. I would do it from the back.
Okay.
I would do a costotransversectomy of T5 from the back, plus or minus a C7 PSO. But
we do have standing X-rays.
Yeah.
So this is him. We did discuss some options with him, and then also send him for second opinion referrals, actually at UCSF as well, for second opinions before we discuss any
He
further.
crashed at Laguna Seca, so. And the car that he crashed with was a over $1 million vintage Porsche. He's actually lucky that he survived.
Yeah, I mean, you'd think with that background, he would have been able to find the doctor to treat his initial injuries, you know.
Yeah, so he toured the West Coast for opinions, and then he ended up in the place of last
Flex
resort.
X, as well.
So very difficult. What Bob said is right. I mean, this is, at this point in time, a extreme swan neck with an upper thoracic kyphosis and a cervical. I don't think we have the CT here, but the cervical spine is still mal-reduced, and the facet joints are actually dislocated. And you can't get to his neck, really, because his manubrium is in the way.
Okay.
So
You actually just do an osteotomy.
Yeah.
You come through the clavicle, come through the manubrium, and roll that piece out, and you're right there in the anterior spine.
I almost wonder if you stage this, you correct the thoracic spine and bring him up a bit, whether that'll open up the anterior access to the cervical
You
spine.
can actually go. You can go simultaneously. Yeah. You get two. You get one surgeon working in the back, one in the front, and then you're able to kind of look through the area. Harkin and I did this several times with that, and you get your best fixation if you're doing it simultaneously when you're anteriorly and then posteriorly, and then you can lock everything in, because you can basically, the only thing holding the head on at that point is spinal cord, and so you can move it around as you need to with that.
Yeah, I think just looking at the X-rays, it seems like what's probably driving the greatest amount of deformity is sort of the 45-degree angulation, sort of at C5 and C6. So this is a fixed deformity. Yeah, regardless of how much you split, I just don't think you're going to get down to that anteriorly. So this is essentially like a 2-level costo from the back. So.
Okay.
all right, let's see what we did.
And so, as discussed, we'd stage it. We first started from the back. I removed all the hardware, redid the instrumentation, also went down all the way down to L1. Then putting in temporary rods, thoracic levels, we went anteriorly for the second stage to do that cervical discectomy and corpectomy at C6-7, and then returned posteriorly to add further fixation as well. Continue our infusion, place bone grafts, as well as cross links in multiple locations as well. So this is what we did.
Yeah, that's exactly what I would have done.
So back, front, back. Yeah. And
So that anterior part wasn't so bad after you did the
We did the thoracic release.
Yep.
We did the posterior hardware removal, posterior instrumentation, did the costotransdiscectomy to get that upper thoracic spine out. I put temporary rods in there, then flipped them around, did an anterior osteotomy. So through left, through right side. So we got a full release, put that anterior graft on the anterior plate, then turned them around, did the posterior part. We did a full facetectomy on the posterior C-spine also.
Yeah.
So C6-7, I think we fully resected the lateral masses.
Yep. And then we also began doing this with GW tongues, like
Dr. Oskuian, I'm eternally grateful, in case I haven't mentioned that.
Yep.
No more Mayfields.
And so, again, this is, now he's over 2-3 years out, continuing to do well. Back to working with the cars, not mechanically, but,
He's
still
raced
driving.
again.
He's still
raced
racing?
again.
Oh.
He's raced again against. Yeah, so this is his main joy in life. He wanted to sit back in his classic cars, and he has quite a collection, and he's quite a notoriety on the racing circuit. But I was not thrilled to hear that he's racing again, but
Yeah. And so again, in summary, dropped head syndrome, understanding it's a complex multifactorial problem, treating the whole spine, remembering the 10 commandments of right patient, right surgery, right procedure. We do have one of the interesting spine cases which discusses this, so if you could follow it up on YouTube for further information related to drop head syndrome. And now, Dr. McGuire, thanks.
thank you. So thank you all for your comments, and it's a huge honor to introduce